This video is on neonatal jaundice. Jaundice is caused from hyperbilirubinemia. So to understand the causes of hyperbilirubinemia, let's look at bilirubin metabolism and how each step may be abnormal to result in jaundice. So the first step is breaking down of red blood cells, or hemolysis, to cause hemo, which is then converted to biliverdin, which is then converted to unconjugated bilirubin. Unconjugated bilirubin then travels to the liver, where it becomes conjugated. Conjugated bilirubin then goes into the intestines, where it can be urinated out or pass the stool, or re-enter the enterohepatic circulation and go back to the liver. So causes of neonatal jaundice. So if there's jaundice on day 1 of birth, or it's conjugated jaundice, this is always pathological. However, you can also have physiological jaundice, and this is unconjugated hyperbilirubinemia and occurs within 2 to 8 days. And this is normal because a baby is born with polycythemia, so too many red blood cells, and the body, or the spleen specifically, needs to break this down via hemolysis. Also, liver enzymes that do conjugation are immature, so not working at its full extent. However, there are also pathological causes of unconjugated hyperbilirubinemia, and this relates to increased production. So the baby may have a hemolytic anemia, and risk factors for these are an ABO blood group mismatch or rhesus incompatibility, but rhesus is rare as this is often picked up on screening and treated. Other causes include a G6PD deficiency, which is an enzyme, or cell wall abnormalities of the red blood cell, such as spherocytosis or elliptocytosis. To investigate this, a hemolysis screen is done, which includes lactate dehydrogenase, bilirubin, and haptoglobins. A direct Coombs test can test for hemolytic anemia as well by detecting the antigens on the red blood cells and whether or not antibodies are being produced against them. Blood film can visualize the red blood cells and pick up cell wall abnormalities such as the spherocytosis or the elliptocytosis. Hematomas are another common cause, such as cephalohematomas, which are basically head lumps and are associated with a vacuum delivery. So the other way you can get increased unconjugated bilirubin is if there's decreased conjugation, and this can be the case if the baby's been breast milk fed, or Gilbert syndrome, which is Stowe's disease. Other causes include sepsis or hypothyroidism, and you would do a septic screen, including an FBC, a blood culture, a urine culture, and a lumbar puncture. Conjugated hyperbilirubinemia occurs with issues after the liver, post-hepatic. And the most concerning is biliary atresia. This is diagnosed with an abdominal ultrasound after fasting and shows an absent gallbladder because the gallbladder is so small. This is treated with a case A procedure, but unfortunately this often doesn't work, and biliary atresia progresses to cirrhosis, which, if you've seen our video or sheet on that, you will know it's irreversible. And this requires a liver transplant. Other causes of conjugated hyperbilirubinemia include choledochal cysts, so cysts in the common bile duct, cholelithiasis, tumors, or strictures. Hepatic causes are also possible, but this is due to cystic fibrosis, where there's blockage due to thick fluids. Complications such as kernicterus occurs because unconjugated bilirubin can cross the blood-brain barrier. And bilirubin is a neurotoxin, and this causes irreversible issues such as cerebral palsy and developmental delay. Acute encephalopathy can manifest as seizures or hypertonia, so the baby would be hypertonic, have neck extension, extended back and legs, and look really rigid. Chronic encephalopathy can affect the basal ganglia, leading to movement disorders. Thank you for watching. If you learned something, please tell a friend who may also find it useful.